Mm-hmm.
Well, hello, and thank you for joining me today. I'm really excited for this conversation today because the guest that we're about to speak to is one of the more qualified people in the world to talk to you about your oral health and the development of the human jaw in general. And I've been following her work for some time now, and the amount of knowledge and the amount of expertise she brings to this space is just quite remarkable. So, Dr. Marianna Evans, thank you so much for joining me today.
Thank you so much, Stephen, for inviting me. I'm looking forward to our dialogue and the discussion.
You're one of the rare people in the world with a dual speciality in orthodontics and periodontics. So this is, quite unique in itself. But to start with, before we started to get into some detail, which you have, a lot of, and I'm looking forward to just sitting back and bathing in your brilliance. But I thought we could go back into how did you ever, how did you follow the path of becoming a dual specialist, and in particular orthodontics and periodontics? How did that come about?
Well, it was an interesting story. I originally, when I was in high school, I really wanted to become a doctor and apply to the medical school. And I come from Ukraine. I was applying for medical school back in Ukraine in 1996, 97, I think. And when I was applying for the medical school, I had an option in the application to apply to medical dental pharmacology. And the last minute I changed my mind and I applied to the dental school. I knew a lot about dentistry, and especially that I didn't want to be a dentist for a long time as a child, because both of my parents are dentists and my grandma is a dentist. So I grew up in the dental world. I was used to be like the last patient to get the teeth checked, like waiting for your mom to be done with everyone else, and you are the last one to be basically checked and treated, and playing with the failing materials in the dental office. So I never wanted to be a dentist as a child until I was applying, and the only reason I applied to the dental school was because I felt that from the very beginning I will know what I will be doing in the end. In the medical school you may apply and you have a long time, years, to decide who you actually will end up being. And then when I started the dental school, and I really liked the basic sciences, but when the time came when we started to have like dental classes on dental anatomy and waxing, I did not like it. And I wanted to switch back to medical school. So when I went to the dean's office to discuss the options, what it will take for me to switch, because it wasn't late to switch. The first 2 years of dental or medical school are very similar in Ukraine. So the dean told me that I should not give up on the dentistry, and I probably, if I like more medicine, I should consider periodontics. And this was kind of the first time when I was in the second year of my dental school that I learned about periodontics, and I started to learn more about it, researching, and there is definitely more biology, surgery as part of periodontics, and I really became very interested in it. So I kind of was on the path to become a periodontist. And in Ukraine, we didn't have a specialty of periodontics. You can only practice periodontics as an oral surgeon with some additional continuing education classes in periodontics, or as a general dentist. And I eventually graduated from the special residency in oral surgery with the inclination toward periodontics, and applied to advanced standing programs in the United States, was accepted, and ended up in University of Pennsylvania. I was accepted to NYU, BU, and Penn, and just by knowing the history of periodontics and how much University of Pennsylvania program contributed to the field of periodontics, I chose University of Pennsylvania. And one of my first classes was by Dr. Van Arsdal on perio-ortho, on the interrelationship between tooth movement and periodontal health, the molar uprighting, orthodontic extrusion. And I just fell in love with it, and I thought to myself, this is exactly what I want to do. And I applied for the perio-ortho program, and that's basically the long story.
It seems like you were kind of born to do what you're doing, and you tried to escape, and it pulled you back in.
I don't know. It's just like everything happened so for a reason, but in the same time very spontaneously. And I do not regret even for a second, like doing what I'm doing today. So I was very lucky to have good guidance, good mentors, and just a lot of inspiring people that came across my life, my path, my professional path, and I am very fortunate to end up doing and becoming a perio-ortho specialist. Mm-hmm.
It's an inspiring story, and it's a speciality that a lot of people just haven't even heard of. So, I'm looking forward to kind of helping people kind of understand how you look at the mouth and the development of the mouth in particular. But some of your work begins to focus on the history of the mouth and what jaws. How jaws have looked in human history. Can you tell us a little bit how you began to work in looking at these kind of aspects of human health, and how it began to shape your perspective of your practice?
So I was always interested in understanding the question, why? Why do you develop periodontal disease? Why do you develop malocclusion? What is the link between malocclusion and periodontal breakdown or periodontal health? And to be honest, everything that is happening in your body is a mirror image what is happening in the oral cavity. So just by looking at the patient's oral health, you can answer a lot of questions in terms of what is happening to their overall health. And I think as you start practicing orthodontics, aligning teeth and maybe expanding jaws, and you treat periodontal disease with scaling and root planing or some osteosurgery, if you start asking a question why, it automatically will take you to the systemic health of the patient. So I think I got a very good, solid basic education in periodontics and orthodontics at the University of Pennsylvania. And I learned in my residency how to treat malocclusion, how to treat periodontal disease. But I think as of today, not only in dentistry, but also in medicine, there is not enough focus on in medical and dental education on why we are developing, how does this disease developing, and why is it developing, and when it starts developing. So I was in my perio-ortho specialty, I'm lucky to see adults and to see children. So I see adult patients with manifestation of significant periodontal breakdown, complications of malocclusion, patients are losing teeth, need implants. And then I see little kids that are in transition from the primary dentition to the permanent dentition. You see those periodontal problems such as gum recession or susceptibility to gum recession developing in a young age, poor oral hygiene, how it relates to development of the dentition. So you start kind of making a connection that there is something happening in a young age that is going to progress into adulthood when it comes to malocclusion and also periodontal health. And when we started to ask more questions, why does malocclusion develop, why periodontal disease develop, it actually led me and a lot of other scientists and specialists in the same field to look into ancestral health, to see that modern diet, changes in our diet, changes in our in the loading of our facial skeleton, of our dentition, played a very critical role in making us more susceptible to periodontal disease. Like the amount of sugar that we are intaking or advertised to us to basically intake is ridiculous. Processed foods. This all causes inflammation in the body and predisposes to periodontal disease, and especially if you introduce this food to young children that has very low nutritional value and also very higher risk for bacterial growth, you will realize that there is a significant link between the diet and facial development of the dentition, bone biology and bone development, especially in your jaw structures. And all these factors are going to affect the periodontal health throughout your life, and also development of malocclusion and overall health of the patient. So I think I became interested in this topic, and it just is a very big continuum. Like you just continue learning more and discovering more, and it doesn't end.
It's fascinating, isn't it, how we think of the way a child's dental arch develops, and that connection to their risk of periodontal disease later in life, which we know has that host of systemic issues. That connection is very rarely talked about. So it's really interesting to think of it in that way. How would you see? Actually, we'll go into that later. What I thought we'd talk about first is this anthropological development. What you see in kids today, was it differing from what you were seeing in the skulls of developing children in our past? Is there something happening to our children today where we're not growing as much as we used to? Have you observed that?
Yes. So this is a very, when you look at the difference in the anatomy of the face of pre-industrial skulls and today's patients, there is a very significant change in the facial development. And the change that we are noticing in modern humans, industrialized faces, basically is at the level of the dentition. So we are developing significant crowding. We don't have room for 32 teeth in the mouth anymore. We are designed to fit 32 teeth for a reason. So many of us need wisdom teeth extractions. Many of the children have so much crowding that they can't even fit second molars, canines. There are so many kids today with blocked out maxillary mandibular canines. So our jaw structures are shrinking, are not growing to their full genetic potential. So we have the technology today with 3D imaging to scan the skulls of the pre-industrial humans, and also we scan today's patients just as part of our orthodontic and other medical evaluation. And when you compare the anatomy of the face of the pre-industrial skulls and modern faces, there is a significant shrinkage in the upper jaw. That means that the upper jaw is not developing, and recession in the lower jaw. The upper jaw is the base of your mid-face and the base of the nose. So we simultaneously see the shrinkage and decrease in the volume of the nasal passages. Many of us today have deviated nasal septum, and that genetic potential to grow we all have. So instead of growing in width and instead of growing forward, our faces with the postural changes, habitual changes in our society, with the changes in the diet where it's not loading our facial skeletons enough, is basically growing more down. So that potential that the face has genetically to grow forward and grow horizontally is used to grow in the vertical direction toward your spine, toward your throat, toward your airway. So this is probably one of the reasons why so many patients today have issues with nasal breathing, have chronic nasal congestion, susceptibility to allergies, predisposition to sleep apnea. I think even restriction in the soft tissue in your mouth, such as tongue or tongue tie, is becoming more common because the tongue is attached to the mandible. And if the mandible is not growing, it's getting shorter. So I see a lot of these children with severe mandibular deficiency also have short attachment of the tongue to the mandible. So there is shrinkage that at the level of the bone that is affecting now the soft tissue. And we have completed a very interesting research at the University of Pennsylvania Anthropology Museum that has one of the largest collections of pre-industrial skulls, where we were able to compare today's patients to those samples, and there is a significant difference in the anatomy of the face that we have as a society to address, and there is something that I think is possible to do about it. It's reversible, in other words, problem. Yeah.
It's a really interesting point, the development of the mandible and ankylosglossia, yeah, because that I don't see that discussed very often. What is causing so many children to have issues with oral ties, and so it's interesting to go back into development. Has some of your work looked at where this is happening? So you mentioned the undergrowth of the mandible.
Mm-hmm.
When is this happening when you're observing in the skull? Is it happening during the growth development stages? Is it happening earlier? When are you pinpointing this as when kids are experiencing these growth issues?
Well, I think we still don't have a lot of answers to this question, because I think a lot of the skeletal problems that we have identified in the field of orthodontics, we thought are genetic. And I agree, some of these developmental problems, because we are talking about developmental issue here, not a genetic issue, at some point are entering genetic pool. So mandibular retrognathia, class 3 malocclusion is already in the genetic pool, and to some extent even maxillary hypoplasia. Agenesis, like when somebody is missing some permanent teeth, is already in the genetic pool as well. So I think we need to study this question a little bit deeper, because some of these problems may develop besides entering genetic pool, may be developing in utero. Some of these problems are definitely developing after birth. I think the changes in the direction of the facial growth and the velocity and amount of the facial growth has to do a lot with the function. Starts with the head posture, with the mouth posture, with the tongue posture. So if you introduce bottle feeding to an infant, if you introduce a pacifier, if the child from a very young age cannot breathe through their nose and is developing an open mouth posture, if you keep the child in the any type of seat, like a car seat where the head is tilted down during the largest facial growth, basically the peak of facial growth, which is within the first 24 months of life, I think if you introduce that low head posture from a very young age, it also will affect direction of the facial growth because of the gravitational theory. So I think there are so many factors that we have changed to accommodate our lifestyle today that if we start changing one by one, we will see a significant change because the growth within the first 24 months of life is very moldable, and you can change the direction of the growth, you can change the amount of the growth. So I think there is a lot that we can do. And even if there is a genetic predisposition to some of these significant skeletal deficiencies, I think if we intervene in a very young age, we can reverse many of them.
It's such a big problem, isn't it? And it spans so many different perspectives on how we are affecting the growth and development of our children. So such an important topic. Marianna, Christy asks, how can a baby without teeth develop their palate? Are there any existing appliances? Some babies are born with small jaws and recessed maxillas, as you mentioned.
Mhm.
Are you seeing anything in this space?
Mhm. Well, the baby's palate grows the most within the first 24 months of life, and there are studies that actually show that. So if you compare the growth of the palate from age 0 to 24 months versus from 24 months to 10 years, the palate grows the most in terms of amount within the first 24 months of life. So you don't need to have teeth for the palate to grow. What we know is affecting the palatal growth is the position and the pressure from the tongue and perioral musculature. So if you think about physiology of the infant, you are every infant before 6 months usually nurses should be nursing every 2 hours, and the physiologic type of feeding is breastfeeding. So during breastfeeding, you have a significant pressure that is applied from the tongue to the palate, and that pressure develops the palate as the tongue is growing as well. And so if you interfere with the physiologic feeding of the human from the very beginning, or you stop the breastfeeding at 6 months, or under the 12 months, the studies show that the palate doesn't reach its full potential. So these children, if they're examined by the age 3, are more likely, in some studies, like 12-fold more likely to develop posterior crossbite, which is basically an indicator of the palatal deficiency. So the tongue is a very powerful organ. If you are not using the tongue, if you use the bottle, if you have a restriction of the tongue, even if you breastfeed the child that has the tongue restriction or ankyloglossia, other muscles will take over and will compensate, such as perioral muscles like lip muscles and cheek muscles. These are very strong organs, and they will constrict the palate. So not only they will prevent the palate from growing forward and in horizontal plane, they will make the palate even narrower and more constricted. So we have to understand very basic, fundamental concepts, how the face, how the mouth is growing, and how the anatomy is related to the function.
There's so much for parents to start to consider these days, isn't there? And I think it's easy to get a little overwhelmed. Oh, we just lost Marianna for a second there. Let's see. You still got me there, Marianna? Marianna's just had a connection issue. We'll just wait while she reconnects there. If there's any questions for Dr. Marianna, just if you can just try and type them in concisely with a question mark so that we can put them to Dr. Evans a little bit into. We're going to do some questioning now on the growth and development of kids, but also to systemic health and how her view of periodontal health connects to the development of the jaw. So for anyone that's thinking, how certain issues, how Dr. Evans would treat that, if you can put that into the box, and we will ask that in the interview. Just waiting here to see if Dr. Evans just had a little bit of a connection issue there. Just going to send her a text and see if we can. Oh, she's just reconnecting, so just be a second. So we're talking to a dual specialist, periodontist and orthodontist. So the perspective here is really fascinating, because you're seeing how she's thinking about the different types of factors that are influencing not only just the development of crooked teeth, but how systemic health and much broader. She works at the Penn State University anthropologic department, and so a lot of her work there has been based around that.
Sorry, we got disconnected. I'm back.
We're back again. Okay, great. So Marianna, it's amazing to hear your perspective of the broader implications of the development of the human jaw. I thought we'd begin to start to dive into the perspective of what you're seeing in your clinic, and so what parents are experiencing. What's the most common presentations you're seeing in the clinic? Maybe we'll start with pediatric patients. What is it that parents are seeing and experiencing, and what is your view on how you're seeing the best way to address these issues?
So the most common problem that we have patients present with, especially pediatric patients, is in orthodontics, is crowding. Many children today, or the majority of children today, have severe crowding, where they cannot fit not only 32 teeth, but in many of the cases, if you exclude wisdom teeth, there is no room for 28 teeth. We are lucky today in orthodontic profession to fit 28 teeth in the mouth of a child. And the second most common problem is crossbites. A lot of children have posterior crossbites, underbites, open bites.
Can you explain crossbites for the layperson, how that presents, and what the cause of that is?
Sure. So normally, I can actually show the model. Let me show.
Yeah, great.
So can you see?
We can see.
So let me. Oh, perfect.
Yeah.
So this is the upper jaw. This is the upper jaw. This is the lower jaw. Oops. Sorry, this way. And ideally, you want to have the top teeth overlap the bottom teeth. So the lower teeth are contained within the upper jaw and upper dentition in ideal scenario. A lot of patients today present with a crossbite just on the side, when the lower teeth overlap over the top teeth on one side only. There could be a crossbite in the front. There could be an open bite where the front teeth cannot couple. And when the problem is so severe, you can even have a bilateral crossbite where the bottom teeth will overlap the top teeth on both sides, or all across from one side to another. So what it shows that basically that there is a mismatch between the lower jaw and the upper jaw size that doesn't allow the teeth to fit. Ideally, you want the teeth to fit like puzzle pieces, like there is a designated spot for every upper tooth to touch with the lower tooth. And if you have any disturbance in growth, whether it is in shape or in size or in the direction in the upper or lower basal bone or jawbone, the teeth will not fit. And this is probably the most common. And when the teeth do not fit and if the patient has crowding, this is also related with gingival inflammation. So the studies show that crowded teeth are more likely to have bad bacteria around the gums and around the teeth, and that causes inflammation in your body. That local inflammation will have an effect on systemic health, causing systemic inflammation, and can basically predispose to autoimmune disorders, can predispose to heart problems, and also breakdown of the bone around the teeth locally. So there is definitely a significant link between malocclusion or bad bite, crowding, and poor periodontal health. And a lot of these children, if you screen your patients for breathing disorder, and breathing disorder means where we are not using our nose to breathe, we use our mouth to breathe when we have poor sleep, when we keep our mouth open, at least during sleep. Many children today are breathing through their mouth chronically during the day as well. So if you start taking that part of the medical history, which we haven't really taken until recently in dentistry and in orthodontics, you will find a significant link between severe malocclusion, because mild malocclusion is pandemic today. The majority of our population has it. And the severe malocclusion, breathing disorder, and also poor facial development, and possibly systemic conditions such as allergies, diabetes, chronic inflammation in your body, like gut issues, like Crohn's disease. Like a lot of children that are diagnosed with Crohn's disease have gingival inflammation, have periodontal involvement, and are very likely to have malocclusion as well.
There's some interesting questioning here. Have you noticed about Claudia asks, are there any differences between girls and boys, or women and men? Are they more prone to problems because the jaw is usually smaller than men?
Mm-hmm. So when we look at there is definitely difference between gender differences between females and males in the size of the jaw, but we also are looking at the proportions. So we're not only looking at actual size of the bone, we are looking at the proportions. And when we look at the proportions, so there might be a lot of similarities between males and females in terms of how much the upper jaw should be like wider than the lower. But actual size, there are a lot of males that would have larger jaws than females. So I think when we look at the gender differences, there are definitely differences in the post-pubertal patients when you already have introduction of the sex hormones, estrogens, progesterones. So some of the females are going to be more likely susceptible to TMD or temporomandibular joint problems, also gum inflammation, and some type of skeletal pattern like open bite. Maybe some of these patients will have very mobile joints and joint hypermobility and loose ligaments across other parts of their body. So there are some phenotypes that are more disease phenotypes, systemic and oral, that are more common in females rather than males. But overall, when I look at the malocclusion, I don't really see much difference between the genders.
A similar pattern. Just on this topic, Dr. Evans, Christina asks, do female pregnancy and birthing hormones affect periodontal health in women?
Yes, so this is the topic that has been very well studied in dentistry and in periodontology. There is definitely a predisposition due to hormonal changes in pregnant women to have gingivitis, pregnancy gingivitis, high susceptibility to periodontitis, and bleeding gums, and it's all hormonal related. And most of these problems in presence of good hygiene will resolve after pregnancy. So this topic has been studied, and this local inflammation, if you have poor oral hygiene and you are pregnant, that local inflammation at the level of the gums will enter your systemic blood pool and will be a risk factor for premature birth or low birth babies. So this has been very well researched in periodontics. So if you are pregnant, make sure to take care of your teeth and your gums.
Have you seen a rise in issues with women suffering from conditions like PCOS and periodontal issues, or any trends like that?
I'm sorry, I didn't understand the question.
So polycystic ovary syndrome or issues with hormonal problems that seem to be more common today. Have you noticed a trend in periodontal health in people and associated hormonal issues or problems with sex hormone problems?
Well, I think I really haven't looked in depth in that particular topic, like polycystic ovaries and periodontal health, but definitely with even like using birth control pills, that is going to change your hormones in the body. I think you definitely are probably going to affect your periodontal health, because these hormones affect your periodontal health and will affect the reproductive system as well. So I think I haven't really researched it, but I am very curious if there is a connection there as well.
Seems becoming more common, yeah. It's something that I've noticed more and more in medical histories, yeah. But it's definitely, there's definitely that that link between what we see in the mouth and the rest of the body. Dr. Evans, how are you? What are some of the approaches you're taking? So we're talking about all these little jaws and all these bite issues that you're seeing in your practice. What are some of the approaches that you are now finding are more effective in helping kids with these issues? And can you explain some of the processes that you use in your practice now?
So what we realized in orthodontics and also in general in dentistry, that we have nutrition is very important, and it's not only important for the quality of the nutrients that you are introducing to your body, but also for the functional stimulation of your facial skeleton. Like we can go to the gym to improve muscle tone in your body, but we have no gym for the face, right? Like when you think about it, your face basically gets exercises from diet, eating harder foods. So I think, of course, there are appliances that I use that are going to stretch the bones and develop the bones, reposition the bones to a more favorable, redirect the growth of the bones into more favorable direction. But me as the doctor can only do so much. So I think the patients need to realize that there is so much more that they can do at home by changing the diet of the child from a very young age, introducing solid foods to a child from a young age, not giving a child a pacifier, a bottle, introducing hard foods such as like almonds, raw almonds, jerky, hard fruit and vegetables, raw vegetables that the child can eat, will stimulate muscle growth, muscle activity, and if you have strong muscles, you will have stronger bones. So we now see a lot of patients with weak facial musculature. And when we take 3D x-rays of patients that had changed their diet to harder, like even chewing gum during orthodontic treatment 1 hour per day will change your density of the bone when you look at the x-ray of the patient before and after. Expansion will change the density of the bone. Clenches, patients that are clenching and grinding their teeth will have, because they're using their muscles more, will have denser bone. So I think There are things that the doctors can do, such as me, with appliance therapy, like palatal expanders or any type of devices to redirect the growth of the jaw, alignment of the teeth with braces, myofunctional therapy, which is basically professional specialized treatment of any type of orofacial muscle disorder. Besides that, which is the professional care, there is something that people can do at home. And I think we as a society need to educate the public more what they can do at home rather than just rely on the therapies later in life that we can do in children after age 5 or in adults. So I think it's very important for the public to be introduced to these topics and to start thinking about it and planting a seed about what they can do.
I think that's a great point, and especially considering for treatments too, must have found that patients that understand these topics and inputs to the development of a jaw, they have better outcomes too. So it's interesting to think about how we need to talk about this more, so parents and people out there know their role in helping the development of the jaw. It's fascinating. Dr. Evans, Mia Tittle asks, what's your approach to face-forward palatal expansion? So there's this discussion of expanding in certain dimensions. Do you work with devices that grow the face forward? What's your view on this?
So we need to understand that some of the devices that we use will mainly stretch the palate in the horizontal plane. If you basically stretch at the level of the teeth and the level of alveolar bone or tooth supporting bone. But there are devices where, by opening with palatal suture sufficiently and not stretching too much the teeth, you can actually change the position of the upper jaw in the anterior-posterior direction. So we, besides just expanding enough, not only to address the transverse problem, but also to address the AP problem, we use devices such as face mask to protract and bring maxilla forward. And there are limits to these devices when it comes to the effectiveness and also to when it comes to age of the patient. But we utilize as much as possible in our practice devices to grow the maxilla in the horizontal and in the forward direction. And the younger the patient, the more effective this therapy is going to be.
Makes sense. Dr. Evans, there's a question here talking about the effects of all these small jaws. Have you noticed or have you observed that malocclusion may be related to mental health problems, teeth grinding, and insomnia? People seem to be suffering these things more and more today. Do you think it's related to their jaws?
I think that there is definitely a link between the mental health, breathing, facial development, and even parafunctional activities such as the grinding of the teeth. So right now, this research again is still evolving and it's not fully understood. But the mechanism seems to be the one that the parafunctional activity of grinding and clenching of the teeth may be related to hypoxia, a lack of compromised airflow during sleep that is causing brain to trigger basically parafunctional activity of the facial musculature to keep the airway open and bring the lower jaw forward. A lot of patients that have breathing disorder during sleep will also suffer from insomnia. And if you are not sleeping, for whatever reason you are not sleeping, it could be lack of airflow or hypoxia, or could be other reason. They're going to be a link to your mental health. You will not be yourself if you don't get good sleep chronically over time. So I think the link between poor sleep and mental health is already in the literature. The link between parafunctional activity and Poor sleep is already in the literature. And the link between poor facial development and poor sleep, hypoxia, is already in the literature. We just need to connect all of this together. But there is no question that mental health is going to be affected if you have poor sleep or lack of sleep.
It makes sense that the multifaceted presentation, doesn't it? All of these different inputs, resulting in how we feel and how we, how we interact with the world. It's a very complex picture, and there are many things that impact how we feel mentally. Dr. Evans, you're also a mother. You've got a son, I believe, and I wonder how has your work, how has it influenced your life as a parent? I mean, I know myself. I've got 2 kids, and it's been a huge influence on how I've watched them grow and develop. Can you tell us a little bit about how you approach motherhood with this very detailed view of the human growth development process?
So, of course, and I'm actually expecting another child in a few months.
Congratulations.
Thank you. So it's really the knowledge of this interlink between oral health, systemic health, facial development, and systemic health diet really affected my personal family life and the way we are trying to raise our son, and who is almost 5. And I hope that the second child we will be even to do a better job than we are doing with my son. So I think to raise a healthy child in today's environment is very challenging. And I feel really compassionate for the parents that are struggling to do the best that they can do. So I think for me personally, the most difficult and the most challenging was to be able to give my child all the time that he needs during the first 12 months, and especially breastfeed and be able to work, because I run like a very busy practice. So I also have patients that cannot wait for me to be away for 12 months. So I think our society is really not designed, especially in that industrial society in developed countries, to support the women properly. And we have to fight it, and we have to do something about it, because every mom should be home with the child for 24 months. I was raised in the Soviet Union, and the only thing, it was really bad thing, the Soviet Union, but the only good thing about the Soviet Union that I think was important, they supported the mothers, and each mom had opportunity to stay home for 3 years and be paid to stay home for 3 years to raise the child. So most of the children from Soviet Union were breastfed, except if there was a physiologic problem, if it was a premature birth, or mom had health issues. Those children obviously were not breastfed, but they did other bad thing with their children. They introduced sugar and like soft diet from a very young age. As soon as the baby developed teeth, we had cavities. So I think we have to revisit that chapter of how we can support in our society working moms, so they can give the attention to their children to the full potential. So I think that introducing a young child under the age of 24 months to the daycare is the wrong thing, because you are introduced to respiratory issues from a young age that is compromising your nasal breathing is bad. I think the child under 24 months should be raised at home with not as many people as they are introduced in the daycare. I think that we have to do everything possible to allow mom to breastfeed the child. And in the United States, the government went the cheapest path. They are subsidizing the breast pump. there is no breast pump or bottle that we have today that will replace natural breastfeeding. So I think, like, I was lucky enough that I live 5 minutes away from home, so I was able to breastfeed my child till age 3. And it's crazy, but I did it. And I don't know how I did it. Don't ask me. But I think that the moms that want to breastfeed their child and cannot stay home for more than the job is supporting them, like usually in the United States it's less than 6 months, are victims of this problem. And if you breastfeed the child less than 12 months, the facial development will be affected, and we have literature about that. So I think I also read a lot of books how to introduce solid foods to my child, and I'm lucky that I'm from Eastern Europe, so we cook everything for the child. I didn't really introduce sugar to him under age 3. We tried to give him everything natural, and I think it's affecting his facial development. I think his face is developing better than if he was bottle fed or if he was introduced sugar at 6 months formula. So I think it's very challenging, and my situation was very difficult, but in the same time I was very lucky to have a very basic education what I can do, and also to be able to do what I did. But for the majority of moms it's not possible. So I think my advice to the pregnant moms or moms that are women that are trying to start a family, to try to research this topic and try to learn ahead of time as much as they can what they can do to be able to breastfeed. This is the basic thing that I think is going to set a foundation for healthy facial development. They need to learn about pro-inflammatory diet, what foods are bad for you and bad for your child, because the majority of education what to feed your child comes from the grocery store, what you find on the shelf, and what you find on the shelf of the store is all junk. So you have to educate yourself, spend time to learn what do you feed your child every day. And then of course one of the most challenging things are the cultural things. If you introduce your child to school, to daycare, and they see what other children are eating, and the foods that are introduced to like children that we feed in mass, like mass-produced foods like pizzas and all the processed low nutrition foods that children eat in the daycare for convenience, because parents don't have time to cook, don't even know what is healthy for the child. Like when you talk about general population, I think is also very damaging. So it's like a vicious cycle. If you start with a problem like formula feeding, bottle feeding, and then you continue with introducing unhealthy food to the child, how can you expect a healthy systemic development? And how can you expect healthy facial and oral development of the child? It's not going to happen. And if you don't have that foundation set from the very beginning, you are basically at risk of developing major problems for the rest of your life. So that foundation is the key, and it happens within the first 24 months of life.
I couldn't agree more, and it's really kind of obviously very confronting for parents because it's so difficult. Obviously, you mentioned how hard it is for certain situations and your own challenges, but there really is a lack of reinforcement, from our society on how important these times are, and even just a simple conversation like you just had with people on how to think about to frame the stability of a child's life. So it's really great to hear that. I think that's really important. Very basic things can obviously contribute significantly to a child's development. So it's great to hear that, Marianna, and congratulations on your expecting child.
Thank you. Yeah, I remember I was changing my pediatrician, and I went to a new pediatrician. My son, this is just an example of the cultural pressure that we have. My son was 1 year old, and I took him to a new pediatrician, and he wanted to breastfeed. Like, it was time for him to breastfeed. So I remember that face, that look that the pediatrician gave me. What are you doing? Why are you breastfeeding at age 1? It's okay to stop at 6 months. So the biggest enemy that we have today is our culture. What other people are going to say? And that culture really inserted into us so heavily that it's really challenging to go against it and say that there is a better way. We have to do something. And if every one of us will take the challenge of researching and looking into a better way of raising the children, better way to have to be healthy, I think it's going to be a major change for the culture too, for all of us.
Absolutely, I couldn't agree more. Dr. Evans, we're nearing the end. We could sit here and pick your brain all day, but I thought just to finish off, we kind of dive into your view of heart disease and type 2 diabetes are some of the biggest problems facing broader society in terms of risk of death from chronic disease. How do you see this in terms of obviously the connections to the literature to periodontal disease, and what have you noticed in patients in terms of how the lifestyle risks for these conditions and how they connect?
Well, there is a lot of research in periodontics linking heart disease to bacteria and diabetes to bacteria that you see around the teeth in the gums. What is happening is that if you have periodontal disease, and periodontal disease is something that can be controlled and prevented, you will trigger systemic inflammation that is going to affect your smallest vessels of the body, your joints, your heart, your brain. There is even a link between Alzheimer's disease and periodontal disease that was found recently. So I think what we didn't study, believe it or not, in periodontics is the link between the inflammation around teeth, periodontal disease, gingivitis, and sugar. So that, like the link between the diet, what kind of diet the patient has, and the level of inflammation locally in the oral cavity and systemically, I think we didn't study enough. And when I look at my patients in the practice every day, I see that there is a link. There is a link between, if you eat a lot of cookies, you are going to be more likely to have periodontal inflammation versus somebody that doesn't really eat sugar. So I think that is a missing link that was not fully studied in periodontics. So I think there is definitely the connection between diet, periodontal health, and systemic health. And diabetes, heart disease are the most common systemic conditions that are absolutely linked to oral inflammation. So if you can control oral inflammation around the teeth, periodontal inflammation, you will, and you have diabetes, for example, you will also improve your AC glucose level. So I think you definitely can improve your systemic health by improving your oral health, and at the same time vice versa. And I think the diet will be a very big factor if you change it to improve oral and systemic health.
Well, it's not often, Dr. Evans, that you hear a specialist talk so much about diet, so it's very refreshing in that sense. But it's amazing how everything ties in, from childhood development to risk of chronic disease in the future. All of these things, what we're putting in our mouth, has an effect on our overall health. Dr. Evans, I want to thank you so much for spending the time with us today and letting us, see into your world of how you, help your patients, to both grow and develop into the potential that the human jaw and that our face can grow into, but also too for better health. And what have you got on the cards? Obviously, besides a new baby, you're obviously going to take some time off. But where can people find you if they'd like to learn more?
They can find me on Facebook. They can find me through my practice, Infinity Dental Specialists. They can email me. You can add my email. And I think we try to be as accessible as possible for the public to contact us and to answer the questions that patients possibly can have. So I'm always open to discussion and to helping other people get healthier.
Well, Dr. Evans, I enjoyed it thoroughly, and I'm really looking forward to catching up in person finally. But all the best for your second child, and I'm really looking forward to doing this again and diving further into the knowledge of Marianna Evans. Thank you so much for joining me today.
Thank you so much for having me. Thank you, everyone, for listening. Thank you.
Bye-bye.
Bye-bye.